Good afternoon. Again, I'm Toby Douglas. I'm the Director of the Department of HealthCare Services. So I'm going to switch gears and talk about the other component of overall healthcare reform and the Affordable Care Act, which is the transformation of, in our state, the Medi-Cal program. And a lot of eyes, a lot of focus is on covered Cal, but at the same time, we've had a dramatic transformation of our overall Medi-Cal program. And that really goes into several different areas, both from, as we look at the consumer and patient experience, coverage, payment, and delivery system reform. And so I'm going to touch on those areas. First, I want to talk a little bit about those building blocks that, as we came to 2014, what were the essential components that have led to a successful implementation. And it is true, we're grading on a curve, and I'd say we've made dramatic steps forward, even on the Medi-Cal program, but by no means perfect. So talk about those building blocks, and then talk about where are these changes, where have we seen as we look at consumer patient experience, delivery payment reform, what have been those changes in the areas of eligibility, looking at changes we're doing in mental health and substance use disorders, our interactions with the exchange and how that improves the experience. Overall, what are we doing on access and our work on dual eligibles. So first, in terms of where we're at, we have already today, just a few months into 2014, 1.6 million additional Californians that are on our Medi-Cal program. We are over roughly about 10 million on the Medi-Cal program now. And that is due to some big changes and building blocks that we put in place. Most significant is back in 2010, we moved forward with what we called our Bridge to Reform 1115 waiver. Under Medicaid program, you can go forward with special waivers to draw down additional federal funds to cover new populations to provide services differently. And we took advantage to do an early implementation of the Medicaid expansions through what we call in California the low-income health program. We aimed to cover roughly 500,000 individuals through what was a county-based approach, where each county would set up its own structure, create some important components of a primary medical home, eligibility process to screen and enroll them under the Medicaid rules, coordinate with mental health and substance use disorder services, and we aim to bring each county up. Where we ended very successfully is we got 650,000 enrolled in our low-income health program through 54 different counties. So that really was essential. It was essential because what it did is it brought, before 2014, 650,000 uninsured Californians into medical systems, into systems that were coordinating with behavioral health, allowed us then seamlessly on January 1st, 2014, to transition them into Medi-Cal managed care. Now, that sounds easy, bring them and move them, but we had disparate systems. We had to work then with all the local systems, identify these individuals, bring them into a statewide client index system, our state system, then transition them into Medi-Cal managed care. We also had to take the clinical information that our local low-income health programs had on these individuals, again, transition into our Medi-Cal managed care to help with the coordination. All of that's helped both seamlessly identify a huge population and get them into coverage. The other important building block was, and down here, you have had CalOptima Medi-Cal managed care for a long period of time, but we haven't had that statewide. Many counties, especially our smaller counties, for up until now have been fee-for-service, where individuals had to find their own provider. They were paid Medi-Cal fee-for-service rates. It was up to them to find the care and most likely receive wrong care in the wrong setting at the wrong time. And so what we moved forward with, and an important component, was to expand managed care statewide to additional 30 counties. So in late 2013, we moved forward with that expansion. And so what that allowed us to do is now, both with the low-income health program population, as well as we look to new individuals coming on, to be able to enroll them into Medi-Cal and immediately link them into a medical system where they can be assigned a primary care provider, know that they have access to specialty services, and that we can coordinate care to make sure that we're getting the most cost-effective care in the system. The third piece, important building block, and David Maxwell Jolly will talk about this too, is our building of and strong proactive work on building an automated eligibility system to deal with the Covered California and making sure that we had an online system ready. And that took a lot of planning across both. The system is for those enrolling both in Medi-Cal as well as into advanced premium tax credits, Covered California plans. And, you know, a lot of focus has been on our federal system and the problems with it. And what stood apart for ours is that we had clear controls over who was responsible and who was accountable between Covered California and Department of HealthCare Services, really holding our vendor accountable and working through what we needed to put in place by October of 2013, what we could wait to put in at a later date. And what that meant is that we had a system that was ready on October 1st. It was not by any means perfect, but we did not try to get everything in at once. We had to make tough decisions about many pieces that had to wait until later dates. And that again was about making sure that we had those building blocks in place when we started the Affordable Care Act. So that's really kind of just in terms of where we've been. Now, so where are we going? So Medi-Cal has, as I said, going through a dramatic change. On the eligibility front, you have the old Medi-Cal program that's been in place for many years, where we had a very labor-intensive paper application process. We required paper documentation. We required information on your resources, your assets. We required renewals every 6 months. We required making sure we sent out new forms every year that you had to fill in. Well, all that is changing with 2014. We're moving now to a standardized income process that's based on adjusted gross income. That's the same as for those applying for advanced premium tax credits. You can apply using all your electronic information. If you apply online, and all your information can be verified electronically through other data sources, you don't even need to provide documentation of income or of residency. And then when it comes to renewal, if your information again can still be verified electronically, you don't even have to, no one will send you out on your renewal form. You'll be told that you're still income eligible. You have the opportunity to change plans, but you don't have to do anything. And if you do need to renew, all the information will be pre-populated. So this dramatically changed it, turns it into both making it a more consumer-friendly approach, making sure that we're reaching individuals, but then creating the safeguards, the program integrity through, to the extent possible, using electronic means to continue to verify people's income, residency, and citizenship. So we're taking state-of-the-art technology to create a more consumer experience, more cost-effective experience, but at the same time making sure everyone's eligible. So those are big pieces on the eligibility front. Some of the others that impact the program relate to ways of identifying individuals and bringing them into coverage as quickly as possible. We have for our hospitals now, if someone shows up as uninsured in a hospital, that we have a presumptive eligibility program that we've implemented, so that anyone who meets the income standards, attests to those income standards, can get onto Medi-Cal for 60 days until they complete the application process through Covered California. We've also reached out to other programs. Our food stamps program here, we call CalFresh, identified anyone on CalFresh who meets the income levels for Medi-Cal and sent out notice that they can also enroll in the Medi-Cal program. And we've already seen about 65,000 come in through that entry point. So eligibility has changed dramatically. The other big change, and this builds off of some of the work we did on the low-income health program, is the importance of mental health and substance use disorder services. We have learned that the important intersection between having a strong medical system and having a strong behavioral health system. And through legislation, through our implementation of the Affordable Care Act, we've added additional mental health benefits that now our health plans are responsible for providing. Before, unless you were severely mentally ill or a severely emotionally disturbed child, it was very difficult to get mental health services under our plan. Now, our plans are responsible for providing to those who have moderate to low mental health needs with mental health benefits. And what that will create is more of a continuum of mental health services across our plans and then our county mental health that are responsible for those with acute mental health needs. On the substance use disorder fronts, we really had a very bare minimum benefit package. Well, now we're expanding that to include residential treatment, outpatient day treatment services, as well as inpatient detoxification, so that we can, again, have a continuum of substance use disorder services. And that's complemented with responsibilities, requirements we have on our plans to do screening for both substance use disorder services called screening and brief intervention, as well as on the mental health side doing mental health screenings to identify and then facilitate individuals into the behavioral health system. And, you know, as we look ahead for our Medi-Cal program, there are these benefits in the intersection with what's going on in the correction system as well as in child welfare system. It's so important to have these benefits. On the correction system, many of you know, we've done a lot of work at the state of ways to reduce our overcrowding in our prison population for low-level offenders. Well, a lot of these offenders have needs for mental health, substance use disorder services. With the Medicaid expansion, now that we're expanding to all those under 138% of the federal poverty level, the vast majority, if not all, come out of prison are eligible for Medi-Cal. So having this intersection, making sure that you have a Medi-Cal managed care program that they're going to be able to enter in, assigned to medical providers, intersecting with screening and access to behavioral health services, it's a powerful tool for us to improve the health of some of the most vulnerable populations. Another area of transformation is this intersection with Covered California and our exchange, that Medi-Cal is no longer in isolation. It is part of a continuum of affordable health care, that when you go on to Covered California, when you apply online, you're applying for affordable quality health care, and whether you're eligible for Medi-Cal or for advanced premium tax credit, you're going to be able to find a plan and enroll in that plan through it. Now, that's just the front-end consumer experience, but then you start peeling it back, and there are ways that we will, over time, be looking at how do we align our standards on outcomes with our plans. Many of the plans are going to contract over time with Covered California. So looking at overall performance standards, how we align the contract requirements, looking at the fact that many individuals are going to move up and down the income ladder and how that changes, and how do we make sure that it's a seamless transition from making sure the providers are in both networks. We have concepts we've called our bridge plan, where we're looking at having Medi-Cal managed care plans contract in Covered California just for those who are moving between Medi-Cal and the exchange. We also have some state-only Medi-Cal programs where we want to look at linking and providing what we call wrap coverage with the exchange, that they're eligible, these people are eligible for both Covered California and for Medi-Cal. And so how do we bring those two benefits together where they can get the best of Covered California and those benefits, but have no cost sharing that we can do, so it's a win-win. So a lot of changes going on making Medi-Cal not what we call not like your grandmother's Medi-Cal, but a really modernized Medi-Cal program that is in line with what's going on in Covered California, what's going on in mainstream healthcare. And that gets to probably an area where we have a lot of time, is around access. And one of the first things that I always get is, well, your rates are terrible. You're the lowest rates in the nation, so how can you do it? And there's no question that our rates are lower, but there's a lot of context that you have to put on when you look at the rates. Well, and first it starts with managed care. We have moved to managed care statewide. Now our managed care plans have their own ability to contract and set rates. And what we know is that most of our plans, pretty much all of them, pay more than our Medi-Cal fee-for-service. They pay on average 25% to 30% higher than Medi-Cal fee-for-service for rates. And then when you look to specialty, it's even higher. So that's one piece of it that you look at. The other piece is that you have to look at the requirements that we have when we move to managed care about safeguards and protections for consumers on access, our Knox-Keene requirements. which then pushes our plans to make sure that they're doing the contracting. And then when you couple that with that we're having to set rates in managed care that are based on actuarial soundness, that our rates over time are going to align with the market demands. Of course, we're pushing our plans to keep costs down. That's my job to do that. But you can't look at it and just look at our fee schedule and fee for service and say that's it. The other piece, and I think this is important as we go to the future, and you guys probably talked about this a lot, is that visit-based and fee-for-service-based system isn't the way we're going to ever ensure access. When I think of the 2 million or more Californians that are going to come onto the Medi-Cal program, over 10 million Californians on Medi-Cal, we're not going to be able to do it with the system that we have today and just pay more. There aren't sufficient doctors. That's not where we got to look to different models of providing care. And I especially see that as we look to one of our biggest providers is our federally qualified health centers that provide roughly 30 to a third % of our visits for our Medi-Cal program. So a third of our visits that are driven by on a visit-based approach. And given that, we need to look at ways that they can provide care differently, that create the right incentives for our federally qualified health centers for us to do group-based visits, to look at using e-consults, more use of telephone consults, home-based visits, but other approaches to provide care that is not so reliant on physician. And that goes to our plans too, ways that they contract and create bundled payments and the right incentives across our accountable delivery systems to provide the right care, but at the same time getting the right performance and right outcomes. And so that leads to me, the last piece is our big initiative on coordinated care initiative and the dual eligibles. And the reason I end there is because it's so fundamental around how we look at payment and delivery reform. We have two systems that we're trying to bring together, our Medicare program and our Medi-Cal program. We have over 1 million dual eligibles in our state that have been getting care across two disparate systems, having to find, in some cases, having to work with even more when it comes to long-term services and supports. So they're having to navigate this system for the last 50 years on their own. We're trying to pull this all together under an integrated delivery model to create the right incentives, both for our plans for providers to rebalance care, to provide care in a community setting, to interface with our mental health and substance use disorder system, to have the right incentives to work with those. All of this to provide the better care for this population, reduce inpatient care, reduce high use of emergency room, and improve outcomes for the population. And we'll be starting this. I mean, this is one of the most challenging initiatives that we take. The Affordable Care Act has been extremely challenging, but to bring these for the most vulnerable populations brings a lot of different vested interests together. And we're starting in April with the initiative in San Mateo County, as well as in San Diego, Riverside, and Inland Empire, and then beginning in July with Los Angeles County. But we expect this was really at the foundation of where we're going with Medi-Cal, of really looking at ways that we maximize and improve payment and delivery reform with our outcome on getting a better patient and consumer experience and reducing the overall cost of care. So thank you.
Thanks, Toby.